You've been pregnant before, you have seen that positive test, and now it's just not happening. People around you say, at least you have one. But you know exactly what's missing. And you deserve answer, not comfort words. I'm Dr. Handan Namli, obstetric gynecology and fertility specialist with more than 25 years of experience. I help you understand your body step by step, so you can make your next right decision with clarity. If you want a structured, science-based fertility roadmap, you can join my Fertility Master Circle. The link is below. Later in this video, I'll tell you the one factor that gets overlooked most often in secondary infertility. It has nothing to do with you. But first, let me explain something that surprises almost everyone. What is secondary infertility? A previous pregnancy is not proof that everything still works. It proves that everything worked at that specific point in time. That's the key shift. Fertility is not a fixed state. It changes with age, it changes with your body. It changes with time. The medical definition is clear. Secondary infertility means not being able to get pregnant after 12 months of trying regularly when you've conceived before. If you are 35 or older, that threshold drops to 6 months. A previous miscarriage, an ectopic pregnancy, even a termination. All of these count as a prior conception. You qualified for this diagnosis and for a full evaluation. This is not a rare situation. The World Health Organization recognizes it as a real, well-studied clinical condition. You are not alone in this, and you are not imagining it. Why a previous pregnancy is not a guarantee? Here's the thought that keeps so many women waiting too long. I got pregnant before, my body knows how to do this. I understand that thought, but the body you have today is not identical to the body you had during your last pregnancy, and neither is your partner's. Your ovarian reserve, meaning the number of egg number and quality available, declines with age in every woman. A woman who conceived easily at 29 may have a meaningfully different picture at 36. Not because something went wrong, because that is how biology works. And the same is true for sperm. The American Urology Association and Asherman guidelines says this directly. Prior paternity does not rule out a current male factor. Sperm quality can change significantly due to age, health, or new conditions, even if everything was normal 3 years ago. So, a previous pregnancy doesn't mean the answer is just wait longer. It means the answer is let's find out what has changed. The most common causes. Let me walk you through what most commonly changes between pregnancies. Some of these you may have heard of, some will surprise you. Age and ovarian reserve. This is the most significant factor. Echo confirms that fertility begins to decline after 32 with a more marked decline after 37. By 40, the monthly probability of conception is substantially reduced. This affects both the number of eggs you have and how healthy they are. Changes inside the uterus. Pregnancy, delivery, and the procedure that sometimes follow can change the uterine cavity in ways that matter for implantation. Uterine adhesions, sometimes called Asherman syndrome, can form after a dilatation curettage or postpartum curettage. They can distort the cavity and interfere where an embryo can implant. Fibroids are benign muscle growths that can develop or enlarge between pregnancy, depending on where they sit, particularly if they press into the uterine cavity, they can affect implantation. Polyps are small overgrowths of the uterine lining. They are common, often silent, and easily missed without a proper cavity assessment. They matter more than many people realize. Adenomyosis is a condition where the tissue that normally lies in the uterus grows into the muscle wall itself. It can cause heavy or painful periods. It can also be completely silent. The evidence linking adenomyosis to implantation difficulty is growing, and it's increasingly recognized as a contributor to secondary infertility. A cesarean scar defect is another consideration. I want to be honest with you here. The evidence is still developing. Not every scar defect affects fertility, and not everyone requires treatment. An ultrasound or saline scan gives you this actual picture. Tubal changes, if there was any pelvic infection or an ectopic pregnancy between pregnancies, the tubes may have been affected. This isn't always visible or felt. It needs to be assessed if the history suggests it's. Male factor. This is the one I promised to come back. It is the most commonly overlooked factor in secondary infertility, and it should not be. A man who fathered a child before may have very different sperm parameters today. Age, health conditions, new medication, varicocele that developed since then. Any of these can reduce sperm quality. The American Urology Association and ASRM guidelines are explicit. Prior paternity does not rule out a current male factor. A semen analysis is simple, non-invasive, and essential. It should be one of the first things done, not the last. Metabolic conditions and insulin resistance. Insulin resistance, meaning when your cells don't respond well to insulin, can disrupt ovulation, even in women who don't have PCOS or with a new definition PMS diagnosis. It affects hormone signaling, cycle regularity, and egg quality. It can develop gradually, and many women don't know they have it until someone looks for it. More broadly, metabolic health, including weight changes, thyroid dysfunction, and blood sugar regulation, plays a direct role in reproductive function. These are not just lifestyle factors, they are hormonal inputs. They change things. Premature ovarian insufficiency. Premature ovarian insufficiency is when the ovaries begin to lose their normal function before the age 40. It is not the same as early menopause, though they are often confused. It does not always mean the ovaries have stopped completely, but it does mean ovarian reserve is declining faster than expected for that age. If you conceived without difficulty a few years ago, and now your periods have changed, your cycle have become irregular, or testing has revealed a significantly reduced AMH or elevated FSH, premature ovarian insufficiency should be considered. It is not common, but it is real and it should not be missed. New conditions that develop after the first pregnancy. Secondary infertility is sometimes caused by something that simply didn't exist or wasn't significant yet at the time your last pregnancy. Endometriosis that has progressed. Thyroid dysfunction that developed postpartum. PCOS or PMS that was previously subclinical. These are common. They are treatable when found, and they are findable when someone looks. The evaluation. Here's what I want you to know before you walk into any clinic. A previous pregnancy does not remove any step from the evaluation. Nothing is skipped, nothing is assumed. ASRM is clear on this. The evaluation for secondary infertility follows the same structure as for primary infertility. First, a semen analysis, the most important first step for both partners. Results should be interpreted against the WHO 2021 reference values. If the result is borderline, repeat before any major decision is made. Second, ovulation assessment, a progesterone test timed to your individual cycle, not automatically on day 21. If your cycle is 35 days, ovulation doesn't happen around day 21, which means the test you should be done around day 28. Third, ovarian reserve. AMH and antral follicle count give a useful picture, but I want to be precise. AMH predicts how your ovaries will respond to stimulation. It does not directly predict your chance of natural conception. 4. Uterine cavity assessment. A transvaginal ultrasound is the starting point. If a uterine factor is suspected, a saline scan or hysteroscopy gives more detail. 5. Tubal patency. Not always first if your history is straightforward, but if there has been any pelvic infection, ectopic pregnancy, or pelvic surgery since your last pregnancy, tubal assessment should happen early. And one more thing, some clinics recommend immune panels, natural killer cell testing, thrombophilia screens, and vitamin D levels. These are not part of the standard evaluation. They add cost without evidence of improving outcomes, unless there is a specific clinical reason. If these are recommended to you, it is completely reasonable to ask, will this result actually change our treatment plan? And age. I want to talk about age now, not to create fear, but because being vague about this doesn't help. And you came here for clarity. If you are under 35, try for 12 months before a formal investigation, unless there is a known concern. Use that time well. If you are 35 to 37, evaluate after 6 months. Every cycle matters more than it did at 30. If you are 38 or older, do not wait. Evaluate after 3, maximum 6 months, or sooner if there are other factors. This period is not a waiting room. Ovarian reserve declines and treatment options narrow with each passing years. The Asherman and ECOG are consistent on this. The age-related decline is fertility well established. These factors are not meant to alarm you. They are meant to help you make timely, informed decisions. The most common mistake I see in secondary infertility is waiting too long. Pregnancy creates a feeling that things will resolve on their own. For women over 35, time spent waiting without a plan is time that cannot be recovered. Myth and fact. Let me go through 4 myths I hear most often, quickly, clearly. I got pregnant before, I just need more time. A previous pregnancy confirms that conception was possible then. Fertility changes. After 12 months of regular trying without success, that meets the clinical definition of infertility. It warrants investigation, full stop. His sperm was fine before, it is not the issue. Prior paternity does not rule out a current male factor. Semen parameters can change significantly. This test needs to happen regardless of history. I had a C-section, the scar must be blocking everything. A cesarean scar defect can have effects in some women, but the evidence is still developing. Not every scar affects fertility. Not every defect requires treatment. An assessment gives you the actual answer. Something must have gone very wrong during last birth. Secondary infertility has many possible causes, most of which are completely unrelated to how your previous birth went. Age, new conditions, male factor changes, these are common contributors. I created a worksheet for this module and evaluation checklist. The question to bring to your next appointment and the age thresholds written out clearly. Download it from the link below if you haven't already. If this video felt relevant to where you are right now, I want you to know there is a place where we go deeper. My Fertility Master Circle is a free private community where I walk through fertility step by step, with science, with clarity, and without the noise. You don't have to piece this together alone. The link is below. Which part of this resonates most with you? The uterine changes, the male factor, the age piece, or something else? Tell me in the comments. Your experience may be exactly what someone else needed to hear today. See you in the next video.